Great. Welcome, everybody. I think we have a kind of a small group today, which is really nice. This is Tamara Sale again from Portland State University User Center for Excellence. And Lisa, you want to introduce yourself again?
Sure. Hi, everybody. My name is Lisa Dixon. I'm Director of the Center for Practice Innovations at Columbia University Medical Center and the New York State Psychiatric Institute, and I direct the On-Track New York initiative, and formerly was I'm still the principal investigator of the RAISE implementation and evaluation study.
Great. So thanks to everybody who has sent inquiries in the meantime, and it's really obvious that there are a lot of things that people are trying to work through. Today is really focused as a very informal question and answer kind of session. But because we do have a small group, I think there's also the opportunity if people wanted to share what they're working on or kind of the challenges that you're experiencing. I think it really has enough flexibility, and we have enough time to make it a genuine dialogue. And I think Lisa and I are both really interested in the work that everybody's doing out in the community. So as Adam had mentioned, people are able to speak on the call today, and we'll continue that as long as we don't get echoes. And if we do end up having a problem with echoes, we might end up having to go into lecture mode, which would mean that people have to type into the computer, but we're going to try to avoid doing that. So with that, we will sit patiently and invite whoever's the boldest to ask the first question or bring up the first scenario. And you can either type or you can speak, either way. Phone lines are now unmuted. Okay, so I see that there are a couple of folks who are typing, so we will patiently await. Okay, do you know of any programs and collaborations currently underway in Massachusetts? Lisa?
Well, I think you'll have to forgive me for not being able to keep all the Massachusetts programs straight, because I know that I think it's Mass Mental, or no, McLean, that has had a pretty vigorous program, and I think particularly people who are at clinical high risk, and I think now also people with first episode psychosis. I was just actually in Worcester a couple of weeks ago, and of course in Worcester, with I think under the leadership of UMass, and they have a program that focuses more on, or is an adaptation of the open dialogue model, which is not entirely, it's really a slightly different approach, and probably wouldn't necessarily map perfectly onto the CSC, but I think Chris Gordon and others are kind of working on an adaptation. So that's what I know about Massachusetts.
We can definitely go back to the participant list for these calls and try to connect up the folks from Massachusetts, and then also kind of put out the word to the larger TA network to see if people have other recommendations. Of course, Boston University has done a lot of great work, maybe not specifically on early psychosis, but we certainly use their materials a lot.
Actually, as I think about it, Don Goff's old program, he's no longer at Mass General at the Freedom Trail Clinic, but I believe that a number of people who worked with him and have considerable expertise in First Episode, including Oliver Freudenreich and the psychologist whose name is escaping me. She was played a very significant role in creating the early treatment programs model. So, and I'm embarrassed that I can't remember her name, but she's great. So that would be another place to check out. Okay. We're seeing
and then
our.
Christopher is also mentioning two programs: PrEP at Massachusetts General Hospital, I assume that is, and Cedars Clinic at Mass Mental. So maybe folks could send recommendations to Edward. I don't know if, Edward, I don't know if you would want to share your email address for folks who want to. Okay. Oh, there we go. There's a website. And we're getting some beeping. I'm not sure exactly what the cause of that is, but if it becomes problematic, let us know. Maybe the Institute folks could see if you can check that out. Okay, so there's another question online about people who are screened out, our experience with EASA, and we hadn't talked specifically about the experience with On Track New York. That a large percentage of people get screened out. Can you talk about those ineligible and where you refer them, how you establish community relationships with community providers that need care but don't meet early first episode criteria? Not a lot of mental health agencies have youth-specific programs. Yeah, so I think that is one of the challenges in your community, that you're going to face some folks who are experiencing frustration around accessing care, and your program is going to look really appealing to people because of providing something closer to what people actually need. So it's just, I think it's something to understand up front that that's part of the dynamic. All of our mental health programs, or all of our EASA programs, are within community mental health centers. So we ask the people who are doing the screening to work actively with the folks who are being screened out to help them identify what resources are available to them, to look at what they actually need, and then to advocate to get that to the degree that it's available within the community. So there are definitely times where people go into a suboptimal kind of program at the point that they're being screened out, and I think that's a broader community issue. The folks in the community, to a large degree, understand that, because it's not like we've been dealing with the perfect mental health system up until now. And generally, they're really happy to have someone who's willing to have that conversation with them. But you're not going to solve all problems. And like I had mentioned previously, one of the things that happened in Oregon as a result of that dynamic was that our legislature came up with additional funding to provide something closer to the Headspace model in Australia, which is kind of geared towards providing support to people regardless of their diagnosis. But that's definitely a much broader level of commitment. So I wish I had a really easy and simple answer, but just recognizing that there will be certain audiences that tend to make more inappropriate referrals, and if you don't offer them some kind of support, they'll stop referring to you. So at least
yeah, sure, I can pick up on that. It's really a very, very challenging scenario, and happens a lot in New York as well, and happened in Maryland So the first thing Tamara alluded to, which is to educate your community about what you can do and what you can't do in terms of potential referrers. And it doesn't really help. I mean, it's frustrating and for folks to be referred and then to find that they're not eligible. So it's in everyone's best interest, I think, to have a really well-educated referral network. So that's one piece of it that I think we didn't quite realize at the beginning, but we've learned that we have to do. The second thing is, of course, then when people who don't meet your inclusion criteria, you do engage with them. I think the first thing for us, there's kind of the number of different scenarios, and as we're now moving to more rural areas, I see it playing out a little bit differently. Now that we're in more remote areas where there's fewer providers, we're working with the planners, the local leadership, to educate them about this probability, and in some sense, if there's only one or two agencies in a big geographic area, then we have to work with them to make sure that they have something, whether it's just what they had before, or that they're prepared to take folks who don't meet the formal criteria of the program, and that's actually worked out pretty well. They kind of know going in these less populated areas that they're still going to want to serve everyone that sort of comes into the door. In our more urban areas, it's a little bit different, and what because there's a lot more providers around, and so obviously the one thing that we do is just really get to know our neighborhood. We really get to know, who's in town, where it's possible for us to refer folks, and then just really being that resource person, and our outreach and recruitment specialist, or that person who plays that role on the team. That's one of their jobs, is really to know the neighborhood. The second thing that has happened is that, as in some sense, as the whole community has become more educated and in some sense excited about the approaches that are embedded in these CSC models, is we're actually seeing new services pop up that maybe that have broader criteria, or are maybe able to meet the needs of individuals who don't meet the strict criteria. So in some sense, trying to create to fashion this as you interact in the community as an opportunity for innovation, kind of in the larger system. But it's very heartbreaking. I think in particular when people have insurance, private insurance, and what their insurance pays for is so limited. And if they were to meet the criteria for our program, we would provide them with services. We provide them with services regardless of what their insurance status is, or if they have insurance or not. So I think part of what Tamara was saying is that there's a little bit no getting around this, but there are ways, I think, to mitigate the to make the whole community better by this process.
Yeah, I think that's a really important point. And let me also just really quickly check in, because I'm hearing a periodic beep. I don't know, Lisa, are you hearing that as well?
No, I'm actually not hearing a beep.
It may just be me. So okay, all right. So I can handle it. So that's not a problem. But if other people were hearing it, I thought we might have to switch to lecture mode. So, I think that also kind of related to what Lisa was talking about, as you educate the community, one of the areas that we've talked about quite a bit within our state is kind of the general phenomenon of adolescents and young adults not accessing health care at the exact time period where there's the kind of typical age of onset, both for major mental illnesses and for a range of other medical conditions. So, we've tried to kind of tie our issue to a broader kind of adolescent, young adult focus, and really kind of bring attention to the fact that this has been kind of a neglected population historically, where we've assumed that people in this age group are just automatically well. But in fact, we know that even coming in the door, we have quite a few people with metabolic disorder already, and kind of a range of different conditions. So, I think if you, again, as Lisa was saying, if you can think about it as an opportunity for innovation and lay the groundwork for a broader vision, and especially tied to the healthcare reform efforts that are starting to make services more accessible to folks. You may actually be able to get farther down that path than anybody's accomplished so far if you kind of start with that type of vision. So let's see. Laura asked, how do you anticipate changes in healthcare access will impact funds for EASA programs? Well, just right off the bat, we've already had a major impact. We've gone from 30% of the people in our program being uninsured to only 8% in a matter of just a few months. So that was a tremendous shift, and that was attributable almost entirely to people going on Medicaid, which kind of surprised me because I thought we would see a lot more people on private insurance, and we actually haven't seen that in the way that we had expected. So, one of the challenges, even though we have a very substantial legislative appropriation, is that people have had a subsidy, and at the same time we're going into statewide expansion, and so there's some kind of restructuring that has already started to happen around the kind of how much of a subsidy people receive and what the expectations are around how much they're going to bill and that kind of thing. So I think it'll start to redistribute the kind of the funding. But more generally, I think the fact that folks are eligible for Medicaid based on income is going to have a huge impact on the young adult population, because they almost all qualify just based on income. So it means that it's automatically going to be much more sustainable for folks going into the front door. For those states that have done Medicaid expansion, which I know is not universal at this stage. The private insurance, I think, is still more problematic, and I'm hoping that with the parity law, that will that has enough groundwork that the service array that's typically provided through public mental health centers, but is not accessible to privately insured people, the fact that folks can't access it because they have the wrong insurance, even though there's a medical necessity for that care. I'm hoping that we'll hit a critical mass where we'll get either the legal rulings or the insurance system framework to basically say that private insurers need to be covering this type of care. And there are a number of structural issues around that, like most of the social workers in our programs are not licensed, so we've been pushing them to get licensed, but that takes a period of years, and the whole kind of team approach is is not funded appropriately through fee-for-service. So there are lots of issues like that we're still working on. And I think there's some different models out there that people are developing, but it's not like we've figured it all out quite yet.
One way, just to thinking about ACA, and that we've certainly seen a number of young people who have private insurance coverage from their parents, and maybe this is wishful thinking, but to the extent that these private insurers are then stuck with relatively big bills from the services that are used by these young people, they may be motivated to think more in a more innovative fashion about whether some sort of capitation or some kind of more flexible way to provide services more in the model consistent with these coordinated specialty care programs. But so much of this is on a state-by-state basis right now.
Right. Yeah, and I think that the point that you made, Lisa, about the size of the bill that people can receive is really important for people who are developing new programs. If you're going to open your program up to a broader population, having some kind of a mechanism for determining how much somebody will be billed and how that will be pursued is really important, because otherwise people will titrate their own services, or they won't engage because they feel like they can't afford it. I know that the University of North Carolina folks at the OASIS program have offered themselves as kind of an example where they've been really successful with negotiating those billing situations. So we can share their resource information if you're interested. So what other questions do people have? Does everyone feel fully ready to implement their programs? I know I've gotten a few emails that would suggest that's maybe not totally the case for everyone. I have a couple of folks typing.
Just so you know, I'm hearing a little beeping now. So.
Oh, you are? Okay.
It's a very soft little beep. Beep, beep.
I'm not sure where it's coming from. Hopefully it doesn't mean my charger on my phone is about to die. But okay.
While folks are typing, I can just report that there were a number of questions, people asking at the webinar last week about strategies to assess fidelities and outcome, and I'll be able to have some of that. We're revising our forms now, and I can make that available probably by the end of the week.
Yeah, and also I'm in a meeting right now with some folks up in Canada talking about exactly that same topic. So I think there are a couple of kind of alternative methods or approaches that we could share. We have a fairly extensive fidelity process in Oregon, and the tool is available on our website at isacommunity.org. Has a fidelity section as well as a practice guidelines section. So I think what you'll see is there's kind of a range between kind of a minimal and a more extensive approach, and we haven't quite gotten to the point yet nationally where we have total consensus on what that should look like. Sandra has asked, does anyone across the country have experience with models that minimize or even avoid antipsychotic drug use, such as soteria?
I think Tamara may have, did we just lose Tamara?
Yep, it looks like she's going to have to relog back in.
Okay, so I'll follow up here. So
Okay.
Sandra's asking about whether folks have experience with models that minimize or avoid antipsychotic drug use, such as soteria type programs or open dialogue type programs. I can just say that in general, I think most of the programs, well, the program in On Track New York certainly tries to minimize, but I don't think that's exactly what Sandra's referring to. I think the question is really, Sandra, if I can articulate what you might be asking, ones that really are overtly trying to really avoid antipsychotic drug use. So I don't, if anybody else has information about that, we have not in New York or in Maryland as a part of RAISE really had that kind of position, or we try to minimize antipsychotic drugs, but of course kind of definitely offer it as a part of kind of the toolkit, obviously all according to a shared decision-making model. So if anybody on the phone would like to speak up, type in, and we'd love to hear from you. I have another, so I'm going to give a minute for folks to respond to that.
Okay. Hi, I'm back.
So hi, Tamara. So in talking about Sandra's question, I expected that, or my sense was that what she was referring to is not so much programs that are just trying to use the least effective dose, but programs that are really oriented to avoid antipsychotic drugs. And I asked if anybody in the audience group had experience with that. And that orientation would not probably apply to On Track New York or to the Maryland Connection program. So I've not had personal experience with it.
Yeah, I think we've had some conversations with folks who are involved with the open dialogue discussions, and also within Oregon, there's a fairly strong desire to try to minimize antipsychotic drug use. The general philosophy of most early psychosis programs is to start low, and also to not immediately put people on medicine if the duration has been very short. There's definitely some debate about we get pretty regular calls from folks who are advocating about not putting people on medicine at all. And most of these programs also have quite a few people who are choosing not to go on medicine. We don't force medicine on anyone, and so there are quite a few people who are not on it. In fact, the folks from Canada who we're meeting with today were just saying that about a third of the folks in their program don't take any medicine at all, and another third take it kind of intermittently, not as the psychiatrist would have prescribed. So the reality is that even if it's not intentional, these programs typically have quite a few people who are not taking medicine, and that there is a pretty strong participatory decision-making focus. The fact that you have a range of alternative methods of treatment at the table working with the person is really important, because I think that does help to reduce the need for medicine by providing additional structure and that sort of thing.
And I would, Tamara, it's interesting. I think your numbers are probably pretty consistent with what we're seeing here in New York.
Yeah. Yeah, I don't know, I haven't seen any compelling evidence that for people who have schizophrenia that not using medicine is effective overall, like if you were to do that with everyone. There are some issues around kind of what is the underlying cause and making sure that you're providing the right treatment. What we have found is that quite often people in the community are more likely to prescribe than we are. We're often reducing and sometimes even taking people off of medicine. So there's definitely an active debate about this, and there's some very, very strong feelings on all sides. In the first webinar, we talked about some of the data that suggests that people's longer-term outcomes may actually be better off if they've gone off, if they've not stayed on medicine. But there's very active debate about this, and research that would probably support both the short-term efficacy and the kind of long-term challenges of medicine. One thing that I think being involved with early psychosis work does as well is it does blow away some of your assumptions. There are definitely people who we would have thought really needed medicine long-term who were able to do well without it. It's been really clear that medicine only really gets people to the point where they can engage in treatment. And then at that point, the recovery process really kind of works from there. And medicine is not like the answer to the condition by itself. But Sandra, I think that's a really important conversation and one that we can continue. So Bill is asking, do you have any information on the continuation of the 5% set-aside funds? It seems like a network of state implementing CSC with these funds would be very helpful. So are you talking about whether it's going to be an ongoing set-aside? Yeah, okay. So, there is I think this is not a question that I feel comfortable answering, but we certainly know the people who do have the answer. I think that the idea behind it was to start something that is ongoing, but we can ask some folks at the federal level to respond to that. Lisa, do you have any inside knowledge?
No, I mean, I think it would be, my hope is that it will be continued, but it would, it would just be irresponsible to say, because, it's certainly a complicated process, and I wouldn't know for sure, and I wouldn't want anybody to make like major decisions on the basis of the hearsay and the rumors that I'm privy to. So.
Yeah.
But I'm a cup is half full person, so
right.
I'm thinking positive.
Yeah, I mean, it seems like, even where you've got really sustainable funding, typically, it's done on a budget by budget cycle, and so nobody's ever willing to give you any kind of guarantees. When we first started our program, we had 9 months of funding on the table, and here we are 14 years later with a statewide dissemination. So if we had not started accepting people into the program based on the fact that we had short-term funding, we wouldn't have been able to kind of segue to that point. But it is a political process for sure. Anybody else want to share any inside information that they have, or kind of share what they're doing or ask questions? I think maybe Bill's question about the idea about the network of states implementing CSC is a really important one. So we should we should think about that. Lisa and I have been involved in a series of discussions about creating a formalized national network, and I think that that's likely to happen because there is enough need for it and enough folks who are wanting it. So we can bring that back to the folks who are organizing that, which include people from NIMH as well and SAMHSA.
I think that one way or another there'll be some opportunities to join a network. How active that network is, what it does, I think is still up in the air, but there's a real desire nationally to connect the dots so that as in some sense as a nation we can create a learning community around this challenge.
Yeah. We have a listserv that includes everybody who's been part of these webinars, and so I think from the beginning, everybody who's been on the calls is a resource to each other, and then I know there are at least two kind of simultaneous efforts around creating a national organization. And Kelly is typing. These calls are a good example of what it's like to communicate with a person experiencing psychosis. You have to leave lots of time for them to process information and to get it, to express it. Different level of give and take. Okay, Bill, I'm impressed with how long Oregon has been implementing CSC. How did this come about? Well, we started as a 5-county managed care organization, implementing it across 5 counties without all of the elements of CSC. We gradually kind of worked our way to where we are. I think it came about in part because the Oregon Health Plan included prevention and early intervention in its mandate, and it created these local organizations, and the Mid-Valley Behavioral Care Network really took that to heart. Also, the Early Psychosis Prevention and Intervention Center in Australia had been going for about a decade at that point, and there was a lot of international research, so they were able to pick up on the international research to get it going in their 5 counties. And it basically snowballed. It started with a pretty high level of commitment by 5 counties. They were able to bring on foundation partners who were willing to help support making it a population-based intervention. And then we brought a bunch of key players to the table around sustainability, in particular our Director of Mental Health for the state and our Director of Vocational Rehabilitation for the state. And that ultimately led to a state appropriation. And I think that happened to a large degree because the state was having some issues under Olmstead and having a problem with their state hospital. So they were under Department of Justice jurisdiction. They had to rebuild the state hospital, which cost a lot of money, and they were able to identify the early psychosis work as a way of keeping people out of the state hospital. So it just kind of, it took about 3 legislative sessions, and we had folks coming to the legislature and telling their story, and that made a really huge difference. So Kelly, thank you so much for sharing the information about the Felton program. You have a listserv of California early psychosis practitioners, and there's a reference there. That's fantastic. So yeah, the more we can all coordinate, the better. Yeah, so right now we have, we're starting to build informal communication channels, and so I know Steve Adelsheim at Stanford is really working hard to try to bring folks in California together, but he's also involved nationally. This PetNet concept, or the name PetNet that's being used in California is the same name that's being used nationally at this point. So if there are folks who are particularly interested in being part of the conversation about developing a national network, there is a strategic planning group that is being put together, and I think that the intent is to be more versus less inclusive. So you can let Lisa or I know about your interest, and we'll also try to keep everybody apprised. So let's see, I'm hearing somebody running their dishes, which is not quite a dog barking, but any other, or I should say, what other questions do people have? Efforts that are going on out there that you'd like to share? Research you'd like to point people to? So we may be signing off before the hour and a half, which is fine if it comes down to that. I do see that Kelly is typing. So in terms of training, Felton and CIBHS offered this webinar on CBT for psychosis. Yes, thank you. And we'll be offering training in CBT later this year. So Kate Harding, who's a real expert in CBT, has done quite a bit of training, so that's a really great resource. Thank you for sharing that, Kelly. Yeah, I did receive an email from someone asking about data sources, and I would encourage you to go, if you haven't been using it, to use the essential elements of coordinated, what's the name of that, Lisa, the paper?
Coordinated specialty care.
Specialty care. Yeah, there's a section in there about the research base that includes references to a number of meta-analyses. So we can send a link out to everybody to that document. And then I know I also had gotten a request for a link to the original congressional language for the 5% set aside, so we can send that out as well. So Ming is asking, is there any plan for continuous coaching and consultation through conference calls like these from states, for states newly implementing early psychosis programs? I think that's a really good question. There is I know the National Association of Mental Health Program Directors is going to be providing technical assistance to the 5% set-aside folks, and I'm not exactly sure of what their plan is in terms of coordinating the technical assistance. And Lisa, you and I have talked about kind of collaborating, and I know that the Felton Institute has some resources, and the Peer Training Institute is available as well, and the Navigate folks. So there are a number of different groups all kind of offering pieces, but it's not fully coordinated yet. So I think we need to really kind of figure out how that's going to be coordinated. I know that's a little bit confusing to states right now.
I think, this is Lisa, I think my best guess is that there will be some type of kind of more big picture types of coaching calls. What I don't see that will, I think, be required is the kind of more hands-on, almost at the clinical level, consultation. And so, there's this kind of, there's the how you organize things, how you set it up, but then there's the need, I think, and I think what's going to happen is that different programs will seek out different consultants or advisors that will get down to more of the person-to-person level. And I think that people at NIMH and SAMHSA are quite aware of the need for both these levels of consultation and supervision, if you will. And so there's a lot of discussion going on now about how to, how to assist states in getting, what they might want and need. So it's complicated because there are a number of different like there's the big picture, and then there's, okay, I have this person that I'm working with, and we're facing this situation. How do I move forward in a manner that's consistent with the model, or am I doing this right? Am I implementing this program right? And that's kind of a much more micro level. Then I think will be able to be supplied on these kind of big calls.
Yeah, I think that's a really important point, and Ming, I appreciate you bringing it up because we do know that it's one thing to go through kind of initial training, and it's another thing to receive longer-term coaching and supervision. We've also found within Oregon that doing on-site fidelity reviews has been really critical to identifying challenges that might have been overlooked otherwise that were really significant. So, there's definitely some significant kind of infrastructure development needs nationally, and each state is in a slightly different position. So, in California, there are at least 5 universities that are really actively doing this work, and a couple of them have reached out to their local communities and are doing the kind of ongoing support for folks. So in those states that have expertise already established at some level, I know like Vermont, Ken Minkoff was talking about a practice center they've developed there. So there are some places that are going to have a stronger infrastructure they can turn to, and then for others, there is this kind of network of folks out there. We've also turned historically to folks internationally. We've done a fair amount of work with folks like Jane Addington and the Australians, which of course is quite a bit more expensive. So let's see, Ming saying Utah now has a basic understanding of the program, but there will be many questions as we start to implement it, in addition to accessing consultants. It also would be helpful to have an ongoing call among peers to learn from each other's implementation process. And I think that that sort of thing should be pretty easily doable. There is enough infrastructure among our institutions to establish some kind of ongoing call, and I'm definitely experiencing that there is a relative generosity among the folks who are experienced in the field, who are often quite willing to be part of those types of calls, like Lisa on this call, who who's is valuable at a very high level in terms of hourly rate, but it's generous in terms of her desire to help people implement. So Ming, I think that's a fantastic idea, and maybe that's one of the first things that PepNet could think about, is trying to support something like that. And I know I'm going to be seeing you on Tuesday or Wednesday, so we can continue that conversation.
Yeah, I think in New York and Maryland, and I anticipate in our work with programs nationally, that the idea would be really to seed knowledge and expertise, but that's really kind of a short-term proposition. Ultimately, we'll be working with communities to have them become the experts and then be able to seed their own communities and move out from within their own state, teach others. So it's really kind of a train the trainer that who trains the trainer and trains the trainer kind of model. But it's a matter of, I think, in the initial phases, just kind of making sure you have somewhere to turn to if you have questions, and also just to have an independent observer making sure that you're implementing kind of implementing reasonably. So, but certainly the whole notion of peer support, whether it's the whole different array of peers that are involved here, is exactly the right way to go, and I think is pretty cost effective.
Mm-hmm. Yeah, I think that there have been some things that we've learned both within the early psychosis field and more general as we as we move forward. So I mean, excuse me, I'm reading and talking at the same time. So we've definitely learned that it's important both to train people initially, but also there is a need for ongoing training, because you'll have turnover of clinicians, and so every new clinician coming in needs to have some level of training. And then there's also a need for some form of ongoing consultation and supervision, and some form of kind of accountability, or looking at what's working and what's not working in the community, and continuous improvement. So I think we're starting to define what that infrastructure looks like. And I know every state, as you've looked at how to implement individualized placement and support, or ACT, or whatever models you've taken on at a state level, the more we can get to that point where we have some kind of state infrastructure, or maybe regional infrastructure, where people are working together, I think we'll have a lot more consistency in the long run. And every state has its own strengths. So hopefully 5 years from now, 10 years from now, we'll have a bunch of different TA centers all around the country. So other questions. Oh, Christopher has raised his hand. I'm not sure what that means. Does that mean that we have to? Okay. I hear that. I'm not used to people raising their hands. Okay, so Christopher might have a question. So let's see, is he muted? I'm not seeing a way to communicate with him. Oh, he left the webinar, okay. All right, well, I assume he'll send us an email. Okay, are there other questions or clarifications or other pieces of information people have shared? You know, this has been a really good conversation, and there's a lot that Lisa and I will want to follow up with in terms of this idea of some kind of ongoing peer process, as well as, you know, Kelly, I know you had shared about the CBT offerings. You know, one of the things that we are talking about within PepNet is just making sure that the word gets out about all these different resources, and also that there are links to archived locations where people can access things like these webinars and the Psychosis webinar or the CBT webinar for future reference as well. You know, and you know, Sandra, your questions about antipsychotic drug use are really, you know, kind of one of the most dynamic, that's one of the most dynamic questions that's going on out there. And, you know, again, there's an active dialogue and people sharing research. So that's something we can bring into the themes. And Bill, you had asked about the mental health block grant, and we'll see if we can get some more information out to people about kind of what folks are anticipating longer term. So, you know, there are lots of important questions that come up each stage of the way as you implement these programs. And you know, what you'll find is that there are some areas where there are really clear answers, and then there are a lot of areas where there's still some significant debate, and there are some areas where there's really, really high levels of evidence, and some areas where it's more consensus. But, you know, once you get into it, you know, I think your experience will probably be similar to what ours has been, which is that you're going to hear from the folks who come into these programs that they're very well accepted. People really see them as kind of the way it should be, and you know, so they have a kind of a life of their own almost once you get them started.
Before we stop, I wanted to take advantage of the moment to let you all know that some of you may have seen the planning tool that was posted on the NIMH website and is also on our On Track USA website. And what we tried to do in the last several weeks is make it much more user-friendly for people. And the new and improved version is now both available on the On Track USA website as well as on the NIMH website. And what we really tried to do is make it very clear where you could put in your own numbers for the size of your community, and you could plug in your own estimated incidence, and we give you the numbers from the literature regarding like what's the incidence of just non-affective psychosis and what's the incidence if you include all psychosis, and So you can sort of select your incidents based on the population, your population of interest, and then you can plug in what your desired, like how many people in your population you want to approach, how aggressive and how ambitious you're going to be. You can plug in how many of those people that you've approached you think will agree to services. You can plug in how big your teams are. You can plug in how long you want your treatment to be. You can plug in how costly your teams are, and it will give you all kinds of information about the cost per team, the cost per client, and so we have, the way that it's set up is that the numbers that you can plug in are highlighted in green. So if you're still thinking about planning for your population, please take another look. And if there's something about the tool that doesn't work for you or that's confusing, please email me, because we really want to try to make it so people can use it.
Yeah, it's a really great practical resource.
I can put the link into the chat box.
Yeah, that's great.
It's just fun to play with, too, if you're inclined in that direction.
Yeah. And I know, as we go back and review the various questions that people have asked and sent us over time, we may want to do some additional webinars based on some of those topics, or maybe design some fact sheets or some things that are responsive to some of those questions. So this whole process, I think, has been really helpful in terms of defining what types of supports people are needing at the local level. And so we'll try to come up with some kind of summary follow-up documents based on the feedback that you've given us over time. And then also, if you have suggestions about additional resources that you'd like to have available, I know, Ming, you had some thoughts on that, or specific topics that you'd like to learn more about. I'm sure that there are others who are having similar questions, and we'll continue to try to provide support to you guys as you go further down the road. So it's 12:07 my time, which is in Calgary, Canada, which I believe is 2:07 Eastern Coast time. And I'm not seeing anybody typing or raising their hands at the moment. So we'll give it a few more minutes and see if anybody still has a latent question. I think it's probably okay for us to end the session early. I don't think we have to go to the advertised time. You all have our email addresses. I suppose we could also type those in for folks who might want to get back in touch with us. So we may send out some kind of a follow-up survey to folks, seeing if you want to be, if you want to be part of a national directory, or what kind of involvement that you would like to have, whether the series met your needs, that sort of thing. Thank you, Ming. I hope that the series has been helpful to people. We've covered a lot of ground, and the big picture is important, but the details also are equally important, and it's not always totally obvious how to get from one point to the other. I know it's a lot to think about. We do have several people, and they're all saying, thank you, that's nice. Thank you. I'm glad to hear from folks that they have found it helpful. And, again, I know that people still are going to have ongoing questions, and you know how to reach us. So, Lisa, do you have any thoughts before we?
No, I've throughout this whole technical assistance process, I've just been so impressed by the commitment and depth of kind of inquiry that you all and others who have been a part of this process have put into it, and I just it's really exciting. And as one of the COOs of an agency where we have an on-track program was saying to me the other day that she feels that this program is a very exciting, potentially transformative agent for the whole agency. Mm-hmm. So that what is being done within this program, she feels it provides this really living, breathing example for what she wants to have happen throughout. So, it's very exciting, and I appreciate all your questions.
Yeah, thank you, Lisa. And I think that's a really great point. I hear that a lot as well from our agencies, that basically what we're trying to do in the early psychosis work is to bring what we know works to people more quickly and provide it more consistently. And so most of the practices are actually things that you would probably want to make available to a broader population. So it has been our hope from the beginning that it is a transformative thing for the whole system. I think that's probably a longer-term ambition, but I think it's an important way of framing it, because especially in the rural areas where they're talking about how difficult it is to implement a specialty program, if you recognize that the practices are actually that actually have a lot of relevance across the whole agency. A lot of the kinds of things that you need to do to make this work are really agency-wide and really require top-level leadership. So hopefully this can be kind of a mechanism for you all to pursue some of your broader goals as well. So so thank you everybody for joining us, and since I don't see anyone typing right now, I think we can probably wish everybody a great week, and we'll look forward to ongoing dialogue with you. Thank you.